Good morning. Hello, everyone. Thank you for being here. My name is Lindsay Fabian. I am representing the Policy Forum Committee who helped plan this wonderful event today, and we're happy to see you all. We are live on Zoom, and we have a bunch of people on Zoom, so we will be using the microphone so the Zoom people can hear us at home. It is my pleasure to kick us off by announcing my friend and colleague, Kristen Moore, who will moderate today. She's a past president of MPHA, and she will tell you all about herself and why we asked her to moderate this event. So, Kristen, welcome.
All right, I'm going to try to stay close to here. I am a wanderer, though, so let me know if you can't hear me. Hi, everyone. I'm Kristen Moore. I'm the immediate past president for MPHA. In my day job, I lead the real-world evidence generation planning for a small to mid-sized pharmaceutical company called Jazz Pharmaceuticals. Happy to talk about that more later, but we have our panelists here, which are going to really lead us on a rich discussion there. First, as we start all of our MPHA events and meetings, I'm going to read our ancestral land statement, and then we'll get into the discussion for the forum today. So, we ask that you take a moment to honor and acknowledge that we are on the ancestral homelands of the Dakota and Anishinaabe. Indigenous people have a long-standing history and connection to the land since time immemorial, and are the original stewards of lands and waters. Many American Indians were forcibly exiled from their lands because of aggressive and persistent settler colonialism and U.S. governmental policies, but they persevered. We make this acknowledgement to honor the Dakota and Anishinaabe people, ancestors and descendants, as well as the land itself. All right. Well, thank you all for being here for the second of the policy forums this year. We're really excited to get started here. I think what's great is that we're living in this period of really extraordinary scientific acceleration. And that means a lot of things for us in public health and also in the pharmaceutical industry and in governmental policies that are being put in place. And so it's really this group of people that need to work together to figure out the best path forward. But the speed that we're working at is really only part of the story. Approval for pharmaceutical products is not just a scientific milestone, it's really a systems event. It affects costs, access, equity, infrastructure, and trust. And when a new therapy is approved, we must ask who benefits first, who might be left behind, and what and where are the safety signals being captured, and if they're being done early enough to tell that there might be a problem, and making sure that we have cast a broad enough net to be capturing these events in all people. We're really seeing efforts to modernize the approval and oversight process. And so bringing in AI and what exactly that means in government, in the industry itself, and where these things come together, and making sure, again, that oversight is in place to make sure that we're doing our due diligence to protect people. So today's discussion is not just how drugs get approved and what happens along that process. It's really how the innovation intersects with public health, with population health, and balancing the urgency with safety, and making sure that breakthrough science is done with affordability and technology in mind there. So as a public health community, our role really isn't just to ask, can we approve this? But how can we do this, and how can we do it in a way that protects the population in which we're trying to serve? So I'm really looking forward to a thoughtful discussion and dialogue with our panelists here. I will just briefly introduce them, and then I'll give them some time to do their opening remarks. We have a number of questions that we're going to go through, and then we'll break for a panel or for table discussions. And we'll have note cards for you all to come up with questions. See, a wanderer. We'll have note cards at your tables, and then we'll bring those up and continue with some questions after that. So first we have Erica Barnes, who's the Executive Director of the Minnesota Rare Disease Advisory Council and an executive branch state agency. Right? Yes, good, good, good. I was like, I did not cut and paste that very well. Janelle is an equity partner with the downtown Minneapolis-based law firm, Carlson Caspers, where she advises clients on a wide range of legal and regulatory matters. And then down at the end, we have Amanda, who serves as the Vice President of Clinical Ambulatory Pharmacy Services at Fairview Pharmacy Solutions. And so I think what we're going to do first is we're going to start with Erica, and then we'll just go down. You can go into more about your background and go into your opening discussion or opening remarks.
Testing, can you hear me? Great. Well, thank you so much. And thank you for inviting me here today. This is really exciting and a really exciting topic to talk about all of the innovation happening in drug development and also some of the changes, both, challenges and opportunities. So my background is just quickly in the way of background in my connection to drug development and research. I began my career as a speech language pathologist. I worked in the hospital system. And in 2010, my daughter Chloe was diagnosed with a rare genetic neurodegenerative disease called metachromatic leukodystrophy. At the time, there was no effective treatment. Bone marrow transplantation was the only option. But our neurologist at Mayo said, we do bone marrow transplantation, but there's this thing called gene therapy, and it's happening in Europe, and it's in clinical trial, and you may want to consider it. So that was the very first kind of exposure I had to the world of gene therapy and drug development for rare diseases. Since then, some of you may know it's been pretty breathtaking, the development of these novel therapies and biologics for rare diseases. So now we have an FDA-approved treatment for metachromatic leukodystrophy, and the challenge, of course, is the enormous price. I believe it hit the market with a list price of $4.3 million per patient. So since then, I became involved I started a nonprofit. My daughter passed away. I started a nonprofit, and then really started to, the nonprofit was for her disease, but really started to see barriers to care, barriers to research and drug development being replicated across all rare diseases, and realized that we really need to take a systems approach to how to do a better job with patient care, clinical care, and drug development for rare diseases. So I became involved in advocacy and worked on legislation to create a rare disease advisory council in the state of Minnesota. That passed in 2019, and I've been the executive director ever since. I also serve on the Prescription Drug Affordability Board that was established a couple of years ago here in Minnesota, so kind of trying to work in that. And I would say that the three spheres and the three paradigms, and you sort of referenced them, Kristen, I think in your opening remarks, the three things that I really try to hold in tension and as the work moves forward is this idea of available treatments, affordable treatments, and accessible treatments, and the interplay of all three of those things. For years, as I was involved in trying to get this gene therapy to market and trying to get it approved, in so many rare disease communities, we think, oh, if only we had an available FDA-approved treatment, that would be so great. It would be wonderful. But of course, that's just the first part. And then we have to talk about accessibility. We don't get points as a society if we develop these wonderful novel treatments, but they're not accessible to patients who need them. And that's a whole nother sort of policy thing. Another thing that I sort of always think about is the issue of regulatory flexibility at the FDA. So I think these, when in 1980, when the Orphan Drug Act passed, that opened the door for a lot of regulatory flexibility at the FDA. And since then, we've seen a lot more. One of the big regulatory pathways that is utilized by the rare disease community is the accelerated approval pathway. And with the accelerated approval pathway, while that's really exciting that we have these novel pathways, it raises the issue of evidence, and how do you balance the need for good evidence for these drugs with the ability to really custom design clinical trials and the need for data. And so that's something that I think a lot about. More recently, we have seen some exciting work at the FDA level and even more pathways being developed. Just recently, the FDA announced and developed the plausible mechanism pathway for genetic diseases. And again, for me, as I think about this is exciting that we have this regulatory flexibility, but of course, we always have to balance that with fidelity to the evidence and how that's going to impact sort of the whole ecosystem. So excited to have this talk as we get going, and I'll pass it on to the next panelist.
Okay, hi everyone. Let's see. I actually began my professional career as a pharmacist and then transitioned to lawyer. So I have experience in the community pharmacy space, pharmacy benefit manager space, at the Minnesota Board of Pharmacy just for a few months, and even in the lab with research of small molecule drugs. For the many years now, I guess, I have transitioned to a career as a lawyer. And there I represent clients in complex civil disputes, primarily also representing clients in the drug supply chain with, complying with or before they get into too much trouble where they're actually getting sued with respect to federal and sometimes state laws, but mostly federal laws. A large part of my practice is patent infringement litigations, and in that capacity, representing pharmaceutical companies. When I say representing pharmaceutical companies, oftentimes we get kind of siloed into generic biosimilar space versus, and the more we think of the brand space. And I do it this way because that can mean various different things. There's various different pathways. But while represent a lot of generic, on more of the generic biosimilar side, that being said, do some consulting with some of the more 505(b)(2) and rare disease area. I guess I'll start this with just saying, just to be clear, of course, these are my opinions. They're not the opinions of any client I may represent, not the opinions of my law firm. I'm sure that's the case for everyone here, but just as a lawyer, that's just always something. I'm going to probably say something that I'm sure, a client probably would not want me to say. So why am I here? I guess from perspective of prescription drug costs and prices, you have all of this stuff that's happening in the background. And Erica alluded to a little bit of this when she's talking about drug approval. But I'm going to go through kind of these three buckets of how drugs get approved. And primarily, I'm thinking about the pathways that are getting you generics, getting you biosimilars, getting you competition on the market. Because when competition comes onto the market, it's kind of Econ 101, prices are going to go down. You can charge a lot more when you're the only one versus if there's competition. All right, so the buckets. And and I'll get into my, Angie's right there. She's going to cut me off when I need to be. But as far as the buckets, the first one is patents. And just, I'm sure, hopefully I'm not getting into too little detail for you or too much detail. But for patents, you have a right for a patent. What that gives you is, generally in the United States, if you invent something that's new, that's novel, your reward for that is 20 years of exclusivity. So you have 20 years to keep everyone else off the market, meaning no one else can make, use, offer to sell the same thing that you have invented. That's the give and take that we've acknowledged in the United States, from essentially its inception. So that's one bucket. The second bucket is the laws. And the laws are put into place so that before a drug or a prescription drug is introduced into the market, you have to establish that it's safe and effective. And that wasn't always the case. So there's drugs that are grandfathered in that never actually went through a drug approval process. Think of aspirin, for instance, but that have been on the market for many, many, many years and just didn't have to ever get through process because we have so much data to show when used appropriately that it's safe and effective. So the laws also, in addition to kind of the safety efficacy and getting approval, also have pathways that set forth how we can get generics onto the market, generic pharmaceutical products in the kind of the small molecule space, or biologicals through biosimilars on the market. So there's pathways. All of that are just our laws, you know, and they're federal laws. It's Congress, it's the president. That those are the laws that we have to follow, and so that's another bucket. And then the third bucket are the rules and the regulations. And generally in this space, that would be the Food and Drug Administration, right? The Food and Drug Administration, based upon the laws that are passed, right? Rules, regulations for us to better figure out, okay, what are we supposed to do as far as companies and what can we not do? Another aspect of that is FDA guidance documents. So those in my space are oftentimes what we use to guide clients, because the laws, even the rules, even the regulations are they don't account for the nuances. They don't account for, frankly, the real world of what's going on. And so FDA will put forth guidance documents that are not the law, they're not the rule, they're not the regulation. But the last thing you want to do as a litigator is get up and say, well, Your Honor, my client did X and Y. The FDA guidance doc said to do X, Y, and Z. The FDA was just wrong. At least up until this point, that hasn't traditionally gone over well. So we follow those, and those three buckets really make up this interplay that you have to follow in order to get drugs onto the market, and particularly generics, biosimilars on the market, which then consequently get you lower drug prices. And it's just important to understand that, you know, it all starts with the laws, really. And we have to all follow them, and most people do. So that's all I have to say for now.
All right, I think it's my turn. Good morning, everyone. Oh, I'm not even on. There we go. First things first, turn on microphone. Can we hear now? Can we hear? Okay. So good morning, everyone. I think this is probably a really intentional progression, maybe. I am representing really the frontline pharmacists. You can think of it, I think, that way. I want to share that there are many flavors of pharmacy. So I think many people think of, you know, someone behind the counter dispensing medications, and there are plenty of those pharmacists out in the real world. And in my teams and bubble, we definitely have our retail pharmacy teams, but also want to share that we have many other pharmacists that touch after we get through all of these approval processes and the laws and the patents and these drugs come out. We have pharmacists that their job is to make sure that, you know, they're good for the patients that they take, and that they're effective, and they're being used appropriately, and that patients can afford to take those. So from my background, I have worked over 25 years at Fairview. I started as what we would call now a medication therapy management pharmacist. We provide comprehensive medication management services. We meet with patients. I have a team now that there's about 80 pharmacists that do this across the Fairview system and in 60 locations. And I have some stats here that I'll share in a little bit across the state. But these pharmacists are integrated into the care team. They meet with patients one-on-one, and they're really making sure that all of their medications are appropriate, that they're indicated for them, that they're effective, they're on the right doses, that they're safe for them, and that, again, they know how to take them. We have lots of other flavors of pharmacies. You have pharmacists who are working in, you know, home infusion and in specialty pharmacy and following up with patients. And, you know, there's a large infrastructure of kind of that part of the care team, and just want to, again, recognize that kind of our role at that point is really to help navigate and to help patients navigate all of that complexity of, you know, being able to have something that's out and approved for them on the market, but how do they sometimes get it, or what is the best fit for them, or what is that best combination? So From the state of Minnesota standpoint, I would say honestly, almost every health system now has pharmacists that are integrated in that way clinically. We are unique, to be honest, across the country. I think there are definitely other health systems outside of the country that have pharmacists integrated, but I don't think that they have the infrastructure that Minnesota has. And some of that was due to our policy and the coverage of these services back in 2006 with Medicaid covering those services as a start. And then, that progression over time. And so, we have a group of health systems that get together and collaborate. And just to kind of give some numbers, there were over 60,000 patients that were taken care of last year by pharmacists in this frontline role. There was over 120,000 visits with over 200 clinics and over 180 pharmacists that are doing this kind of work. So I think it's often not always known unless maybe you are the lucky one that maybe has a chronic condition or needs to meet with a pharmacist, that not everybody realizes that we have pharmacists in that capacity within that. So, yeah, I mean, I think those are kind of the big pieces, as we kind of, again, walk through this paradigm of medications. We don't always get to choose what's covered or not covered or whatever, but we're really there to try to help navigate and help people get the most appropriate therapy.
Great, thank you. Yeah, I didn't realize that it really did work out perfectly the way that we have you sitting out here. So Amanda, you sort of touched on this a little bit, but thinking, and this will be a question for all of the panelists, and we can go down the line, I think. Thinking about federal and state law level actions that are being done, what do you think are going to be the most impactful, either here in Minnesota or again at the federal level around, pharmaceutical drug or just, drug or new devices even coming onto the market?
Yeah, I think that's a challenging question. There is the new Inflation Reduction Act that is out that I do think is impactful. I do think it's hard. It's not perfect, and it's hard to operationalize, for lack of a better way to say that. I think right now there's a lot of noise within that, but that's where really the 10 medications have been selected for this year. There's going to be, and you probably could really go into the details better than I can about all of that, but they're going, different pricing is going to be set around that. The goal of this is to make medications more affordable for people. I do think that there's a lot of complexity within that. And being from a health system standpoint, I think sometimes we get stuck in the middle between what the manufacturer wants to charge for that medication, what we need to purchase that medication for, and then what we are reimbursed for that medication. And that margin is usually not very large. It depends on the medication, of course, but I think that's where you're seeing pharmacies really get squeezed within that. And that's where you're seeing some pharmacy closures and other things. There are some medications that can be fabulous and seem like, they're a GLP-1 making a lot of change within the market. And then what actually the pharmacy is getting reimbursed, they could be losing. I mean, we were losing money on every GLP-1 that we dispensed, or on average, we were losing money. So it's and the patient wasn't, they were really unaffordable for patients too. So it's kind of a tricky, right, situation, which has nothing to do with IRA, except that, the IRA is trying to help with affordable pricing. I think if we look back in time, another big legislative piece was Medicare Part D. And although there's lots of faults in Medicare Part D as well, I believe, I think, again, that's the goal of that in general, was making sure that people can afford their medications, which we all want to make sure they can do.
I'd love to hear what you have to say.
Well, I guess I'm going to distract from the actual question just to with look as far I mean I think it's important for everyone to understand that when we're talking about prescription drug prices, everyone seems to focus on the pharmaceutical companies, and it's pharmaceutical companies and their pricing, and but there are a lot of hands in the trough, a lot of hands in the trough. And the ones sometimes, at least on the generic side, that are making the most money off of the prescription drugs are not the manufacturers, and they're not the pharmacies or the pharmacists. I guess specialty pharmacy I'll take out of that equation for a moment here, but just your traditional community pharmacy. And so legislation often it seems to just pick on, if you will, pharmaceutical companies. And I'm not saying that there are not egregious pricing that goes on and so forth, but I do think that it's a little more complicated, but it is something that people should recognize, that there's a lot of people that aren't making the drug and then are not advising the patients on, okay, drug-to-drug interactions. Does this make sense for me? How do I use this? The pharmacists that are benefiting from the pricing structure that we have in the United States. Health insurance companies are making money off of it. Pharmacy benefit managers who are, and distributors. I mean, if you look at if you look at the top companies with the top revenue in the United States, traditionally you're going to see very high up most of the wholesale distributors of prescription drugs in the United States. And if you talk about certain, rare diseases and stuff, physician clinics making an extremely large amount of money off of, yes, you're administering the drug, but off of that drug itself as well. So that's all out there. Whether people agree with it or not, but that is the facts. And so that's my little soapbox that I go back and forth to. But I think we do need to acknowledge that it's not just the pharmaceutical companies here that are setting prices. A lot of entities within the chain are setting prices and taking a profit from the prescription drugs. So as far as legislation, in my world, some of the newer legislation, the hope is that will drive down costs a little bit. One that, and this is very nuanced, but it happened, I think it was probably about 4 or 5 years old now, but it was called the CREATES Act. And it was a very simple piece of legislation, which I personally like, as opposed to something that's pages and pages long, but very simple. And it allowed for generic biosimilar makers to get access to brand name drugs and to do research and development in order to put forth applications, in order to get, generics and biosimilars and so forth onto the market. Prior to that, it used to be such a game as far as even getting access to a drug in order to start to do the development to bring, some competition onto the market. And like I said, what I liked the most about it is it was just very simple. It caught all of kind of the little nuances that could be out there, and we could do that. Lawmakers could make things more simple. Lawmakers could make things more, black and white in a sense. And I appreciated that one because it has made an impact, because the sooner you get drugs, the sooner you can do research and development, the sooner you can bring something to market, of course. So that's one that comes to mind. Probably least effective would be some of the FDA guidance and some of the rules and regulations surrounding exclusivities. And those are all, of course, based on laws, but surrounding exclusivities and kind of even in the generic realm, like when you get drugs onto the market, let's just use the small molecule space because that's much easier. There are incentives to be kind of the first filer, if you will. And it used to be that there was one first filer. So there was one company that would get 180-day exclusivity, and that was your reward for being the first one to try to bring a competitor, competition, if you will, onto the market. Now that can be 20 filers. And if you imagine the benefit of having, kind of being the only one on the market with the brand, and the prices and the profits that you can get are much, much, much less when you have 15 other people on the market. And therefore, there's more incentive to settle. There's less incentive to really try to get drugs onto the market faster. So to me, and again, I am not speaking on behalf of any client, but to me, that has had some negative implications in the marketplace and getting competition onto the market.
Yeah. So, wow, where do we even start? There's so many, sort of federal and even state things that I'm thinking of. And so, I'm going to really try not to oversimplify when I sort of call out, because, as my esteemed panelists have said, this is such a complicated world and there's so many nuances. But I would say the first one that comes to mind is some of the FTC work going around PBM reforms. That'll be really interesting to see how some of the work that's being done with PBM reforms affects the
And
transparency.
those for our other
Yes.
public health people are pharmacy benefit.
Yes, sorry, our
Yeah.
pharmacy benefit managers. So the sort of those middlemen that work to get rebates and formulary stuff from the manufacturers for the health plans. So I'm really interested to see how some of that transparency might affect the pricing of these drugs. It's very new. I believe there was also some PBM reform that passed legislatively as well, federally, at the federal level. So the FTC ruling with Express Scripts is still, I think, well, the settlement with Express Scripts is done, but then the FTC ruling is still pending, I think. And then there was some legislation that was passed. I think too, as I said in my first part, I think also federal activity that's really going to impact the whole ecosystem of drug pricing and accessibility is some of that regulatory flexibility and some of these gene therapies that we're going to see hit the market. We already have some drug approvals, of course. I think there's 9 FDA-approved gene therapies, but that pipeline is pretty robust. And I think sort of seeing the disruption that and the paradigm shift that will happen from, paying for chronic treatment of diseases that is spread out over a lifetime of costs versus, ostensibly a one-time. Is that telling me to stop talking?
No.
Okay, sorry.
Yeah.
I feel like I'm at the Oscars. Get off the stage. Sort of moving in some of these genetic diseases from paying high costs over time versus a one-time, very high upfront cost, but hopefully ostensibly for a curative treatment. And how we just have to restructure our reimbursement models for that. So that's one. And then at the state level, what that looks like, and one thing that we as the Rare Disease Advisory Council are working on is really trying to address how to restructure our reimbursement model to reflect that sort of drug delivery. So one specific thing, not to get too wonky, but one thing at the state level we're looking at is being able to unbundle that biologic product from the bundled payment that hospitals get, so that those can be kind of considered separately. So we're working on legislation to sort of make sure that unbundling happens in a way that makes sense for our hospital systems. So
Great, thank you. And I will try my best to moderate on some of the acronyms because there are a lot. It's a complicated space and a ton of acronyms. So if I miss any, please just raise your hand and I'll see it out of the corner of my eye. So I really liked, Erica, that you said affordability, accessibility, and availability. And so one of the things that I think is really important is making sure that the drugs can get to the people who need them. And how can we do that in an equitable way? And so I would ask the panelists here, what do you think are going to be the most important steps that we take to ensure that the drugs are getting to patients in an equitable manner, that they're getting to the people that they need?
I think making sure that our formulary designs are reflecting the clinical space more than the utilization space.
Yeah.
I mean, obviously we have to make sure our costs are within, you only have certain amount of resources. So you have to make sure that, but I think that, the big one is those formulary designs. What does prior authorization look like? Is it reflecting the clinical benefit and the patient population that needs it? I think one thing that, again, I know I'm talking from the rare disease space, but one thing that I see that concerns me with formularies is when the formulary is designed based on the clinical trial design versus the FDA indication or the needs of the patient population. So I think that that's a huge part, just really making sure that we're working with formularies to make sure that the people who need those drugs are getting those drugs.
Yeah.
I'm trying to think equitable and accessible. I think it's, I like certain legislation or certain pathways where we allow for instance, people that are at certain income levels that just cannot afford to pay the price that everyone else otherwise would have to pay for their drugs, and that's in the form of kind of this 503 B space, and keeping those pathways available to the to populations where they just cannot afford prescription drugs no matter what, and then balancing that with, I think, the rest of the population that can afford, to a certain extent, can afford prescription drugs. And certainly, they're the back end of all of the other folks that are the other companies and folks, including the pharmaceutical company, that are profiting, that are making money off of that prescription drug. And balancing and trying somehow to kind of balance that. I don't know if that means that ultimately we need to change the structure completely, or if we can make, sensible legislation that allows for certain changes to be made to make things a little bit more affordable. I think for the most part, when you're talking about some of the rare diseases, certainly some of those medications and some of the, or vaccines or whatever it may be, are extremely expensive, but you have to think of it from the standpoint of, you're getting this once, you're not getting it, and then you're not getting it another time, or maybe you're not getting it for another 10 years or 15 years. And having some avenue to allow access to patients that want to take those drugs, with the understanding too that, is this really a cure, so to speak, or is this really improving quality of life to the point where it is worthwhile for someone to be paying $2 million for it? And so it's just, there's a lot of balancing, and I guess I'm just kind of blabbering back and forth and not actually concluding on anything, but I think it's complicated. And I think that as a society, we live in a capitalist society. You'll have the people that know this as a right. Everyone should have access to whatever prescription drug that they want, and someone should pay for it, but not me. And then you have on the other side of things where, well, no, everything needs to be regulated, everything needs to be restricted, and only certain people should have access, and you have to pay for it. And then there's everything in between. And it's complicated with the way that our system is in the United States, and it's very unique to the United States as opposed to the rest of the world. What do we do about it? I mean, I think that there is laws. I think if we could make things better, but it would be painful probably for people that are making a lot of money right now off of prescription drugs. And that's a lot of people, that's a lot of companies, and it's a lot of different spaces. So
And I think while you get ready there too, Amanda, there are rules and regulations or FDA guidance about who makes up the clinical trial population, right? And that is still lacking, even with the additional rules and regulations and requirements around, even the racial makeup of the patients that are in your clinical trials. Even with that in place, and additional steps that companies have to go through if their clinical trial did not live up to those standards, I think still needs to be done in a better way as well. So there's still a lot of room, even with the rules and regulations. So it's pricing, it's racial, and even just where patients are living and who has access to those things too. So maybe you can go into that a little bit too, Amanda, with thinking about the patient getting to patients, right? Or patients getting to you. if that is something that you see in ensuring equitable access to meds too.
Yeah, because I think your first question is a little bit like, how do I cure world hunger?
I know, it's a big one. Yeah.
It's very difficult, and we
Yeah.
would really have to blow up everything that
Yep.
we did, and I think it would be hard. It would be a big change. So I think on the other end, what we do is just try to fight for as much equity as we can provide through the channels that we can. And I can say that our teams, I mean, so to your question, I mean, I think one of the things is being where we are at in our clinics and in our clinic spaces, you know, meeting the communities where we are at, and we are in a variety of different communities. I can speak from our health system standpoint, right? That you're meeting and reaching the people. We're doing a lot through our health and wellness hub. We have mini clinics where we're going out into communities and going into community spaces to provide vaccinations and to provide assistance. So I think it starts within the community and reaches out from there. We have food programs. We have other things that we're doing to not just address their medication needs, but to address the overall needs of the population. On a medication level, I think we do that by trying to care for each patient one by one. You know, we look to assistance programs and what they have. We have grant programs. We have, you know, manufacturer programs, you know, pieces like that that our teams draw on all the time to try to make sure that a patient can afford their medication and they can get the medication they need, ensuring it's the most appropriate medication. And if for some reason they can't have the medication that is financially out of their reach, what is the best next medication to help solve the condition that they have that they can't afford, because taking something is better than taking nothing. To help them with their care. So I think that's a lot of what our teams focus on a daily basis. I don't remember how many millions of dollars last year that alone Fairview found for their patient population with regards to medications and what we tapped into so that patients could afford and take their medications.
Yeah. We are coming close to when we'll break out into the table discussions, but I did want to ask one last question before we do that. We've been talking here now about equity and making sure that patients have access if they need it. But we also have to acknowledge that there are a number of groups of individuals who have been disenfranchised by, you know, the medical community as a whole for, you know, a long, long time. And building on, you know, that history and then some of the more recent, you know, changes that have been happening, you know, federally and at the state levels, how do we begin to build that trust again with, you know, patients, knowing that we have this history of disenfranchisement, but then also that there have been a number of things that have happened more recently that have limited the trust that some patients might have in, you know, medicine as a whole. So if you, and this is going to be even hard, maybe this will be harder, if you had like one step or one wish that we could do as public health or, you know, in the drug development industry to rebuild that trust, what would that wish or what would that step be? Would you want to start? Sure. You want to start?
Sure.
Thanks.
Yeah, so I think that one of the things, if I had a wish for sort of the medical community and medical professionals is, and I've seen a lot of broken trust, even in terms of not just with, you know, historically disenfranchised patient populations, but even patient populations in situations like where a pharmaceutical company will start a clinical trial and then pull out, and, you know, all these families that had all this hope. And so I think for me, one of my big issues with the medical community, or one of my big asks, is thinking of informed consent, and that could apply to education too, as not just a one-time thing you do with a patient, but informed consent being sort of a living relationship. And you're constantly looking for ways to ensure that these patients are understanding what you're just throwing them a piece of paper and giving them education at the beginning. You're really building that relationship, and that's an ongoing thing that you're going to need to do and revisit more than once with patients, so that you keep them understanding these very, and as medicine gets more and more complex and medication, it sounds like y'all are doing a great job in that way. So just more of a relationship than a one-time thing you do at the beginning of some sort of process.
Mm-hmm.
Yeah, just to add to that, as far as the relationship aspect, I think my wish would be, and this stems from just observations and experience working with a hospital, Hennepin Healthcare, and the benefits that you can have just talking with people, going to their neighborhoods, going out into the community, and a lot of times it's on a volunteer basis, right? And having, physicians, nurses, pharmacists, and go and talk to people and answer their questions and explain, here's the evidence-based medicine that we have. Don't get into, politics and all that stuff, but just here's evidence-based medicine. This is what it says. And in communicating with people at, in their neighborhoods. And so whether that be, the vans that are kind of been set up where they'll actually go, and it's like they're basically like made up ambulances that are now kind of little if you think about it, internal medicine facilities, but on wheels. And then going and talking to people in their homes or in their neighborhoods, and answering their questions and doing all that. And then, yes, if they want care or they want vaccines or they want something as a result of that, then it's accessible to them, as opposed to having to come in and get papers and just have sometimes it can be, I'm sure, very intimidating, or someone, if, English isn't their first language, right? Having to go into a clinic. I mean, just so meeting people in their space, but also recognizing that a lot of what you're doing is kind of volunteer, right? You're going and we need to educate people on just evidence-based medicine, and then people get to make their own decision. But that would be my wish, would be just more reaching out to the community where people are in their community.
Yeah.
Yeah, I would echo that. I think that we have implemented something called cultural brokers. So we have brokers that are for our communities around the state that work very closely with those populations and find out what the needs of their communities are. I think it's also, to the meeting where they're at. I mean, I know in our indigenous, our cultural broker for one of our cultural brokers for our indigenous population is one of our pharmacists that are on our team, who, has put a lot of energy into that community. She is Native herself. And so meeting, again, people where they are at, we're sponsoring powwows and doing other things to really, again, understand their culture. So instead of us just trying to make them understand our environment, we also need to educate ourselves and understand their needs and environment. And so I think that's the other thing that I would add, is that we're doing a lot, or maybe I shouldn't say a lot. We're doing some. We can always do more to continue to educate our healthcare providers and our teams about different, ethnicities and cultures, and helping them to be more comfortable as well, so that when they are working with someone one-on-one, that they have a better understanding and they're not coming in with maybe misinterpretations of what they believe that culture is about, that culture is helping them learn about their culture, and that they're taking that back. And so it's really, I think, a two-way street of, yes, us meeting where they're at and understanding their needs, but then also us educating ourselves better and our teams better on those needs, so that they can one-on-one individually help care for those populations better.
Yeah, be better prepared for those conversations,
Right.
and make sure that you go in wanting to build that trust and having put in the effort ahead of time, even to
Right.
learn about it.
And it's
Yeah.
little, I mean, these are not little things, but it's
Mhm.
things like understanding what medications have pork products in them. So when you
Mm.
have someone who doesn't want to have something with a pork product, that you understand that that patient may not want that in their care, to understanding when Ramadan is occurring. So you understand if someone needs to be fasting all day long and how to help them navigate when to take their medications or what that looks like for them. So there's lots of things that we need to take back so that we can really better care for these populations and help integrate that care better. But that also builds trust within them that we're understanding or trying to understand. We're not
Mhm.
going to always understand, right? But we're trying to understand how to best care for them.
Great, thank you. All right, I think we're going to break now for some table discussion. We'll probably say about 10 minutes if that's okay, because we were able to talk so long here. It was great. I had a hard time cutting you all off. So I was just like, yes, let's keep going. So hopefully that spurred some questions that you want to ask panelists. So I think there are note cards on the tables. So please feel free to write those down and we'll come around and pick them up and then bring them up here and answer them at about a little after 9 or so. All right. Hi, everyone. I'm just going to do a quick time check. We're going to come back together in about 3 minutes. All right, I'm going to bring us back together here. So if you can find your seats. There were so many great questions. Thank you all for submitting them. There's too many for us to go through, I think, today, but we'll definitely take them back, use them for future forums. If our panel is ready, I think we're going to start around, and we kind of touched on this a tiny bit in terms of, access, equitable access, but there were some questions. Oh, closer. Oh, serious voice. No, I know. I'll use my mom voice. So I know. Be careful. I got little toddlers running around, so it's loud. So there were a number of really good questions. We aren't going to be able to get to all of them today, but we'll take them back, use them for future forums. I'll try to combine some of the questions. So that's what's going to happen if you don't hear your exact question being asked. But one of the first ones that I want to ask about is access in rural communities. And so what would you like to see, or what do we need to do to improve medication or access to medication in rural areas? And do we see a role for community health workers or, other, providers that could help to sort of fill that role? I don't know if you want to start with that.
I can start. I mean, I
Thanks,
think this
Samantha.
is such an important topic, and I see that it's becoming more and more relevant because I do think, and of course, I'm a little biased here, but from a pharmacy perspective, pharmacies were one of the mainstays in rural communities to help provide access. And I think we're even seeing those shrink in those areas. And so one of the things that I do think that's really important around this, and it is going to take every sort of, I think, professional around this and kind of faceted approach. So I mean that from a community health worker to pharmacists to providers. I think we're going to have to get creative in our rural communities. And maybe let go of some of the things that we have held on to. And what I mean by that is that there's a lot of things that expanded things that a pharmacist could do that they don't do today because they're not paid for those services. And so when they have to decide how to run their business, being able to give a strep test, for example, or to prescribe birth control pills or other things that have been passed by legislature that pharmacists can do, they're not always funded. So that passing of the legislation happened, but it didn't pass with funding. So great, you can do it, but you're not going to get paid doesn't always really keep the lights on. So I think being able to continue to think about how do we expand scope of services and ensure that there's payment for those services so that we can continue to invest in those types of resources is important. I think we're going to continue to need to branch into communities and community infrastructure to help. And then I also think things like the telehealth bills are also really important in rural communities, being able to meet. And I know that sometimes rural communities don't always have the great infrastructure for telehealth visits, but a lot of maybe the clinics or places that they can go in that infrastructure. I know we have, pharmacies and clinics within Grand Itasca and at Range, and we do have a lot of specialty care that is provided via telehealth. To make sure that they have access to those services, even if they're not located in the community. So I think those are some small examples, but things I think that we need to be able to continue to think about. How do we maybe do things a little bit differently, or we have to think of how we approach things differently from a professional standpoint to be able to service those rural communities because it is hard. And I will also call upon the controversial 340B program as well. That is keeping a lot of critical access hospitals and clinics alive right now. And if that 340B program were to be cut, that could be a whole forum in itself, will shutter a lot of those critical access hospitals. So that all needs to be thought about as well in the big picture of that program.
I think it's a really good point that if we could reimburse people for the work that they're doing whether it be in rural communities, but particularly the community pharmacy setting, and pharmacists being permitted to get paid for some of the work that they're doing. I think that would potentially help stop what's happening in particularly rural America, just because there were less to begin with, but the closure of so many pharmacies and so many community pharmacies, such that people really can only access their medicines a lot of times through mail order. And mail order isn't all that bad either, I don't think, right? I mean, that is one way that I guess people can still access their medications without actually having to, walk into a pharmacy and go and get their medications that way and their access that way. But I think that should just be an option. I don't think that should be someone's only means by which that they can get medications. And the way to change that is really, I mean, it's hard to ask people to do things for free. And eventually they just can't do it for free anymore unless they're, I guess, very, very wealthy. And one thing with access, I'll go back to, it does, if from a public health perspective, if people would be willing to more, I guess, volunteer their time to go into communities and talk to people. And so I'm just talking about, communities where English isn't a first language, or indigenous population, or different populations like that, but also in rural America, where the messaging and where, some of the things that people are hearing maybe aren't necessarily coinciding with evidence-based medicine. And being able to have conversations with people and have forums and have the ability to just get out there and say, this is what the evidence-based medicine says. People can do what they want with that, but giving people the ability to be educated in that space could potentially, I think, go a long way to just access in rural communities as well. So that'd just be something that I would add.
Great.
Yes, some of what I'll say is just absolutely echoing what was already said. I think, protecting those independent pharmacies in our rural communities. I'm from rural Kansas, and I well remember Mathis Drugs in my small town. And even in terms of medication adherence with my grandmother, just, Carl Mathis was the one that was really helping her with that medication adherence. And there was a real relationship there. So really shout out to the independent pharmacies. I think too, in terms of telehealth, building on what you were saying, even telemonitoring, using, some of the devices that we have to do some monitoring. I know in the rare disease space, a lot of companies, even with the clinical trial designs, because of course for rare diseases, we've always had a geographical issue with, because rare diseases are so spread out. So using the, the techniques for telemonitoring so that you can get some of that data, even if you're not local, would be what I would say would be a big way to really support the rural communities.
Yeah, and then, from the pharmaceutical company side of things too, I don't know about all of them out there, but I do know that some companies do also have support programs for patients who are taking their medications. And so there is also access or help to access medications there that just needs to be, more widely distributed to providers, to patients, to health systems as well. And so there are a number of different ways that people just need to talk to each other, I think, too. And yeah.
Yeah, that just reminded me, one area that's changing a lot and is the manufacturer direct to consumer. So a lot of times this is the mail order, but I think, to the extent that manufacturers could also develop relationships with community pharmacies so that you could go and pick up your drug there, but you order it essentially online. That is another area that is giving access, whether rural communities or not, but giving more access and at sometimes lower costs than you otherwise would be able to go and get the drug from just the pharmacy setting. So I think that's going to expand more and more and more, is just manufacturer direct to consumer.
I do have to comment on that though, because that is exactly what's going to put our independent pharmacies out of business. So the manufacturer going direct to the patient cuts out the pharmacy. Now there's no margin for that pharmacy, but they want to use that pharmacy as a pickup point or a access spot. They want the pharmacist to take their time and counsel on that medication and to give that information, but then the pharmacist is getting nothing. out of that. So I would argue that's actually, it is going to continue to increase, and it is going to continue to kind of hurt our pharmacy infrastructure with that, because they're really cutting pharmacies out of that.
Yeah, then that's true. And that's where if they can develop relationships with community pharmacies to, I guess you're picking up your drug, but you're also getting educated about your drug when you pick it up, or you're able to ask questions. It still has to, even in that context, be vetted, for interactions and so forth. But yeah, you're right. I mean, there should be a way to at least provide for a fee and to reimburse pharmacies, and still encourage to those patients that don't just want to get their drugs through mail order, encourage, and this can be done again by legislation. The laws could put these avenues in place so that community pharmacists and community pharmacies aren't all going out of business in rural communities. You could be forced to, hey, you know what, you have to reimburse at a certain point or whatever. And so I guess that those things policymakers could do if they chose to do so.
Yeah. Was there anything you wanted to add there, Erica? I saw you lean.
Just kind of more of a
Yeah.
general observation that that I wanted to draw out, and it's not so much a solution as sort of an observation and general observation of, I agree that there are a lot of patient assistance programs, a lot of things set up, but the system is so complicated and so complex and so reactive that what frustrates me is that the people who tend to benefit from that, and when that's used, it tends to be people like me, right? A white privileged woman who knows that I need to go and fight for what I need. Even when we tell patients, it's just unconscionable to me that we regularly tell people in the advocacy space, oh, you know what, try to get this drug, and you're going to get prior auth is going to deny you, but just appeal, and it'll take a couple of appeals, but you'll eventually get your medicine. Well, I mean, who does that benefit? People with the time in their workday. And so when I hear people say things like, oh, well, there's a patient assistant program, or that's not the way it works, I always think, well, yeah, that's great if you're someone who knows the game and you know the system. But if you're in a patient community, or, what about communities where it's not socially appropriate to question authority or question your doctors? So anyway, just a little bit of something to throw out there that it's a little bit of a trigger when people are like, oh, there's plenty of programs. I'm like that.
No, I agree 100%. And I think that is a place too that companies can partner with advocacy organizations
that's
to
right.
make sure that it's done in an impactful way.
In a proactive way.
Yep,
like not waiting for that person to come to me. I'm
Exactly.
going to go find that person.
Yep. And really hearing what those problems are, right? So we do have a question on here that was about all of the paperwork too. So is that a thing? And how can people come together to work to solve those problems and minimize that, or proactively have the paperwork filled out for providers so it can just immediately go when they know they need to switch their patient to a medication or something like that.
Yeah.
All right. I'm aware of time here, so I might have us stick to a little bit shorter answers. Let's see. And both of the questions that I want to ask are big ones. So for drug approvals, how are the standards of evidence changing? Do we feel like we're in a good place to know what is required for drugs to get approved? And I don't know, Janelle, if we want to keep that like strict to like laws and things that are in place, or maybe from your experience, how have companies been reacting more recently?
Certainly, I can start with,
Yeah.
I think it's by virtue of gene therapy, different types of therapies that we have not had on the market previously. And that's why the avenues are changing a little bit, and what we have to do in order to prove a drug safe and effective are changing a little bit, because it's not necessarily a kind of a policy overhaul or anything like that. It's more about, hey, look, we have some new therapy options out there that don't fit into the same buckets that we are used to.
Yeah.
right?
Like,
And
like a cure for a lifetime, right? That
Yes,
evidence
exactly.
standard, how are we going to
How
track
are we going
outcomes
to-
over a person's lifetime for a $4 million treatment? I mean, that's a
right.
totally new problem we're trying to
We're
solve.
used to, a 12-month time frame,
Yeah.
if that. Sometimes you get 6 months, depending on the drug. And then, okay, post-marketing, you have to do another 24 months. And that's just for the phase 3. And now, how do you say, okay, something is effective, yes, pay, it's worthwhile to have on the market. It's going to be something that you can use for your lifetime, but is it?
Right.
I mean, how do we know that without actually having a study? And you can't do it, obviously, it's going to take way too long.
Right.
I'm not saying that, hey, let's go 80 years and then, okay, you can get your drug approved. I mean, so anyway, so I think that it's
Right.
just, I personally believe we can rely on the experts as long as those experts are the ones that are making the decision and those that have gone through all of, understand evidence-based medicine. A lot of the people, well, that maybe used to be at the FDA or still are still at the FDA, that we have relied on. And I trust that, I guess I like to trust that pathways will be put into place, that we can kind of figure this out, but it's not going to be perfect, right?
Yeah.
I mean, and so I think that's it's just everything's changing in the sense that the therapies are changing.
Yeah, well, yes, and like there are the therapies that are changing for sure, and then the guidance I think could also be more clearly laid out.
It could.
For example, some of the the recent FDA saying that they weren't going to review the flu data clinical trial and things like that, and so I think that it's messy. It's messy in a bunch of different places, right? And we can't solve it all at once, but yeah,
And
individual
standards of evidence are changing in that the committees and the expert panels are being changed and some of them being eliminated as well. I mean, we just have to say that that's just happening right now. And so that's going to change standards and evidence and how much evidence is required and what kind of evidence is accepted. So being concentrated in a different type of expertise and a different type of FDA appointment.
Yeah,
It just
yep,
is.
exactly. And I think, from my role too, I focus on, what happens once medications are out there. And so looking at how it's being used in the community, and we call that like real world data, right? That's different than clinical trials. And so the allowance of real world data in some of the FDA filings and using that as potential evidence as well, I think is going to expand the type of information that will support approvals and making sure that, patients are benefiting in the long term as well. So being more flexible in the data that is being allowed might be one of the approaches to help to study or to try to, say that some of those lifelong treatments are really beneficial. But I'm going to pivot us to maybe one last question. And we've talked about access, we've talked about pricing. We would be remiss not to mention that even with access, there are some people who are choosing not to use the medications or the tests that are out there available to them. And so how can we either break down these barriers or create trust with people who are, choosing not to use newborn screening tests or choosing not to vaccinate or use the meds that are available to them. So what are some steps that we as a public health community or as the medical community could sort of take to address those concerns too?
Yeah, I'd be happy to start because as you all maybe are, I'm really seeing, we're seeing more and more opt-outs of newborn screening. We're hearing a lot more skepticism. And I think for me, I feel really strongly that as someone who believes in evidence-based medicine and also has a very real lived experience with navigating healthcare, I feel like the first thing we need to do is acknowledge that some of the distrust is based on a system that was not working for a lot of people for a long time. And so I think it can be easy to be dismissive or smug or, well, why wouldn't people, this is obvious, this is medicine. But when you've when people have been operating in a system that they didn't feel was working on their behalf, I think that trust, you just see all kinds of sort of problems. And so I don't think we should think of these issues out in a vacuum. So a measure of humility is really important. And then in terms of how we fix it, I think another really important thing that I've learned is really trying to listen to, not making an assumption when someone opts out of newborn screening or, some other decision that I think is just absolutely diametrically opposed to what I think would be the right thing, really trying to understand the nuance of where that decision came from. As we were talking about, sometimes culturally, I've had families that I've worked with where they've made a decision to not pursue gene therapy, which is a curative treatment. And a lot of it was based on just some cultural assumptions and some cultural values that I had to take into account. So I think, it all listening, building that relationship, trying to be in it for the long term, right? A long-term repair. It's not going to be a one-time fix to the mistrust. So that's kind of some of the things that come to mind for me.
Yeah, I think that's really powerful, Erica, and I agree. And I think then there's the other opportunity is probably a lot of the misinformation that's out there. And so really trying to do our best to make sure that the information is available and in bite-sizable pieces so that it's digestible for people to understand. Making sure that we're doing that in a way that isn't always at the time of the office visit, because I think it's hard to make a decision then, or there's, it maybe feels more emotional at that time. How can we get ahead of some of those things? And I do think there's a lot of public campaigning that's going on. I feel like my Instagram feed has something, it's probably because I click on it, right? So, but there's something that's there. So I do think that there's a piece of meeting people where they're at and understanding their why and what is getting in the way, and then trying to help make sure that we're combating what I would say is the disinformation against the information. And then I do think that there's a lot of reasons why I'm proud to be in the state of Minnesota right now. But I think also our legislative structure has been amazing in our Department of Health and other things that we have in place right here that has helped protect, those are my words, nobody else's opinion, within that, protect some of that we have in place with newborn screening, with vaccinations. And I think we're going to need to continue to do that. Again, from my pharmacist lens, how our legislation is written right now is that we need to follow ACIP guidelines. ACIP is the committee who approves federally those vaccines. If ACIP next week approves this new vaccine schedule, which would go against what our old standing vaccine schedule would have been, pharmacists won't be able to vaccinate in the state under that. So I think we need to make sure we're changing, that we're legislatively going after that. I know that's on our agenda already. The medical associations and others are going to be following different guidelines, but we need to be mindful of the things that we've also put into place, and how do we do something from a state standpoint, much like we did with COVID when that happened and the state came out and said, no, this is what we're able to do. We're going to need to be able to do things like that. So making sure that we're paying attention to that types of legislation and supporting that, and making sure we're supporting the infrastructure that we believes follows the science.
Great. Oh, yeah.
Yeah,
Real
no,
quick.
I agree with that really quick. I think also we just need to recognize that people have choices in the United States, and we should allow people to make the choices that they want to make for themselves. That said, if you make a certain choice, then the question is, if your choice was the wrong one, should we have to pay for it? I don't know, but that's just something I would throw out there.
Next policy forum idea, potentially. Nice. Thank you.
Teaser.
All right. I know. Well, it's so hard. This is such a complex topic. There's a lot of really tiny pieces in here. So thank you all for joining today. Thank you to our panelists for being here and for sharing your thoughts. I also want to see, I'm a wanderer. I also want to thank the planning committee here too for putting this together. So, and then also to Leica and Mary. So let's give them a round of applause before we close out. All right. And then before we get all excited about the prizes that we have, I have my post-it note of things. So we have the MPHA conference coming up. So you can find out more on the website. There is the draft schedule that's on there if you want to look at who's all going to be there. The early bird registration with a discount ends tomorrow. So take a look now and sign up before the price increases. And then the next policy forum is April 24th. I think there's information on the back of your schedule. It is going to be focused on nutrition and wellness. Oh, that's another big one. Big one. And then if you aren't a member of our MPHA, so we do have a pharmacist MPHA here, so Minnesota Public Health Association. Please check it out and join and continue coming to these types of events and having these conversations with us. So now yes, please share. So there are nominations for the governing council. I know that I've seen how many openings there are and the deadlines, but could you share, Shirley?
Is on February 22nd. And if you look on the fpha.net website, you can get the information and log in if you want to self-nominate.
Perfect. And so I'm sorry, you said there are there's about four openings for those of the people who are joining us on Zoom. So 4 openings. You can find out more on the MPHA website. The deadline is February 22nd. All right. Yes, thank you for reminding me. All right, so we have Starbucks gift cards to give away. I'm going to go with an easy one first. It's going to be who has the most recent birthday. So I'll start. Mine was January 9th. Do we have anybody in the month of February?
Mine is tomorrow.
I think, no, that's perfect.
I have the first away.
No, it's okay. I was going to. Yeah, that is perfect. That is perfect. Okay, second one. So tomorrow is Valentine's Day. For those of you who may not know, that's where some people are wearing red, pink. If that was people's decisions, that was mine. We looked up some trivia questions. And so does anybody know what the most preferred gift for Valentine's Day is? Whoever raises their hand, sorry, raise your hand and then say what it is. Yes. Yes, I will bring this to you. Thank you. I know my first guess was flowers. So, but I also like chocolate. That is fine. Oh, thank you, Mary. All right. And then another fun trivia question here. Does anyone know? Oh yeah, raise your hand. Thank you. Raise your hand if you know the original purpose of those little conversation hearts that usually go out for Valentine's Day or that are often associated with Valentine's Day. Think of the panel discussion that we're having today. I heard something that was close. Medication, it was. So a pharmacist actually developed it for sore throats. And so this is coming to you too. Nice. Yeah. All right. Yeah. And thank you, Angie, for those. All right. Well, I'm going to close this out here. Again, thank you all for being here, continuing to support the forum. These are really great discussions and always a great opportunity to bring people together, get to know, network, but also talk about really important public health issues. So thank you for joining us today. Hope to see you soon.
Oh,